zone in your country of residence. This is Dr. Tandon welcoming you on behalf of IAP and GAPIO. I welcome all speakers, Professor Sudeep and Dr. Rishikesh Thakre, moderator Professor Ruchi Roy, chairperson Professor Rita Raman, and all other participants. This is the fourth session under IAP GAPIO International Lecture Series. Those who have joined for the first time, let me say Indian Academy of Pediatrics is the largest association of pediatricians, neonatologists, and pediatric super specialists. GAPIO is a non-profit organization which was founded by Dr. Pratap C. Reddy, chairman of Apollo Hospitals Group, in January 2011. GAPIO aims to bring 1.4 million physicians of Indian origin in the world on one single platform. GAPIO has members from 53 countries. GAPIO established Global Indian Physician COVID-19 Collaborative on 11th April 2020 when COVID-19 pandemic was declared, with the joint efforts of American Association of Physicians of Indian Origin, British Association of Physicians of Indian Origin, Canadian Indian Network Society, Canadian Association of Physicians of Indian Heritage, and Amiga. Collaborative organized 16 sessions last year in 2020, which included sessions with Sister B.K. Shivani, Shri Sadhguruji, and His Holiness Dalai Lama. During this month only, in the month of June, GAPIO had organized a session on management of COVID-19 in children and management of mucormycosis, and a session with a motivator, Shri Gaur Gopal Das. Let me now invite Dr. Namit Jarath to do the formal welcome note. Dr. Namit Jarath is a senior consultant in pediatric critical care and pulmonology at Indraprasth Apollo Hospital, New Delhi. Dr. Namit has been trained in pediatric emergency medicine from Australian College of Emergency Medicine, Sydney. Dr. Jarath completed his fellowship in pediatric critical care at Sydney Children's Hospital, Australia, and also did pediatric critical care fellowship at the Hospital for Sick Children, Toronto, Canada, before returning to India. Dr. Namit has special interest in management of fluid and electrolytes, mechanical ventilation, cardiac critical, and neonatal pediatric bronchoscopy. Dr. Namit Jarath is faculty and trainer for the following programs: DNB, Diplomat of National Board, Pediatric Critical Care, IAP, College of Pediatric Critical Care, Medversity courses, and Sydney Children Health Program. Now, Dr. Namit, I request you to kindly do the welcome address.
Thank you, Dr. Tandon. Again, welcome to everyone across the world to this wonderful lecture series. As you are aware, this is a collaborative lecture series between the Indian Academy of Pediatrics and the Global Association of Physicians of Indian Origin. The topics for today are based on advances in neonatal care, and it's a pleasure to have a galaxy of speakers, eminent speakers, and moderator and chairperson for this session. We have Professor Sudeep Kukreja from the States and Dr. Rishikesh Thakre from India, who are two speakers who would be speaking on the NICU care in the midst of COVID pandemic and the neonatal care in the first hour of life in the sessions. And to moderate these sessions, we have Professor Dr. Ruchi Roy from India, and the chairperson for these sessions would be Professor Dr. Rita Raman from the States. So we would have an interesting series of lectures, and I welcome everyone. I see a galaxy of eminent people in the audience. There are many people, many of them my teachers, and it's actually an honor to be here welcoming all of you for these sessions. Before we go ahead, may I request Dr. Ramesh Kumar to please come in with his opening remarks. Dr. Ramesh Kumar is a senior consultant and head of Department of Pediatrics at Apollo Etlux Hospital in Kochi. He is the national president-elect of the Indian Academy of Pediatrics 2021, and he would take over as the president of Indian Academy of Pediatrics in 2022. He was the honorary secretary general for 2018 and 2019. Dr. Ramesh Kumar, please.
Thank you, Dr. Namit, respected chairperson of the meeting, of the session, Dr. Rita Raman, moderator, Professor Ruchi Rai, or faculty for the day, Dr. Sudhi Kukreja, as well as my friend, Dr. Rishikesh, coordinator of the GAPIO IAP series, Dr. Tandon, my president, National President of Indian Academy of Pediatrics, Dr. Piyush Gupta, my seniors out here, Dr. Anju Agarwal, Dr. Yashwant Patil, Dr. PMC Nair. I can see a lot of many seniors and academicians from Indian Academy of Pediatrics and friends and seniors who have joined from across the globe. And my dear friends, good morning as well as good evening to my friends across the globe. I'm most privileged as well as happy to join you all for this great series. And as I have learned from right now, this is the fourth in the series. And it's quite resourceful to see that Indian Academy of Pediatrics has joined hands with the Global Association of Physicians of Origin, Indian origin. And this is an international series bringing a lot of knowledge and information from across the globe, bringing the experts from different parts of the world together and sharing and disseminating the knowledge on a common platform, and moreover to the members of the Indian Academy of Pediatrics. And we have got esteemed learned faculty for the day here. And friends, as you say, this is the most relevant session here today, the advances in NICU care, and most relevant to our the Indian scenario, being the largest, India being the largest contributor to the global births. At the same time, neonatal deaths due to second largest population base, of course, and high neonatal mortality rate. And majority of this, as you all understand, occur in the low birth weight, something around 7.5 million low birth weight babies, as well as 3.5 million preterm infants born annually. And of course, there is a huge gap in the availability of trained manpower, especially nurses and supporting paramedical and specialist staff. Hence, more number of training facilities, in-service programs, and more of innovative approaches utilizing the internet and mobile technologies are required. And of course, this has to be standardized to ensure quality and uniformity. There cannot be a one-size-fits-all solution. Of course, because the whole country, even in Kerala, we have got, my state where we have got a high, very low single-digit IMR. There are states we have got IMR of something around 48 or 50. So we need to focus on target district or even block level planning is required. And of course, globally, the care for preterm infants has improved considerably in the last decades. Although the outcome has improved, prematurity is still a large global health issue and is ranked in the top 10 of the WHO list of leading causes of burden of disease. And prematurity still leads to organ injury, especially of the lungs and brain. So the technology in neonatology is a continuous process of involvement. And currently, the technology combined with computer intelligence can support the caregiver in their daily tasks. So technical devices with built-in algorithms that will help caregivers. Of course, almost all the NICU protocols, we have got very robust protocols across, even NHS is having one, and even every academy is having one, and every unit is having one. But this built-in algorithms will help caregivers to maintain preterm infants within safe ranges. And our purpose will be minimizing the occurrence and duration of injurious moments. That's a very challenging job. And there's a ongoing development of technical applications for this. So my take is here, the walls of NICUs have had more prayers than in the churches. So these prayers have to be heard, and we have to contribute, and the dissemination of knowledge to every NICU caregiver, doctors, staff nurses, whoever is involved is more important, and technology has to be combined. And these type of sessions, from the information flowing from across the other part of the world, US as well as from our own country, our faculty is here, and the series are always there. So it is more sure to equip us more with giving a better outcome for all this. So I wish a great session ahead, and I'm sure the IAP GAPIO series is giving more opportunity, will be giving more opportunities to learn more from experts in the field across the world for the weeks to come. And I wish the series all success. And for today, a great session ahead for all my friends and for join for the day. Thank you very much, and I wish you all a great session of learning. Thank you.
Thank you, Dr. Ramesh Kumar. These were encouraging words. And moving on with the scientific session, may I now request Professor Ruchi Rai to take over as the moderator of the session. Professor Dr. Ruchi Rai has completed her MD in pediatrics from the University College of Medical Sciences in Delhi, and has had a training in neonatology from All India Institute of Medical Sciences. She's the professor and head neonatology at Super Specialty Pediatric Hospital and Postgraduate Training Institute at Noida. She has earlier been working as the professor and head of pediatrics at MLN Medical College, Allahabad. She has established level 3 neonatal intensive care unit and was in charge of the neonatal intensive care unit. She has published more than 50 papers in index journals and contributed to 10 chapters in books. And she has special interest in neonatal echocardiography. Over to you, Professor Dr. Ruchi Rai, all yours. You're muted, madam. Yes.
Thank you, Dr. Namit. Greetings to all the eminent dignitaries and the participants. I would like to thank Dr. Namit and Dr. Ramesh Kumar, the President-elect of Indian Academy of Pediatrics, for their opening remarks. I welcome you again to this special edition of the Indian Academy of Pediatrics and the Global Association of Physicians of Indian Origin special edition of this international lecture series. And it's a great initiative, I think, by the Indian Academy of Pediatrics President, Professor Piyush Gupta. Sir has been my guide, mentor, and I have learned all my pediatrics from him and the Global Association to bring all the pediatricians and the other doctors from India and abroad on a common platform. I really want to thank the Indian Academy of Pediatrics, the Global Association, and Dr. A.K. Tandon for giving me an opportunity to be a part of this event. I really feel blessed to be amongst the eminent speakers and other dignitaries today when we are going to focus on advances in neonatal care. Now, the neonatal care has seen a sea change over a period of time, not only in the Western world, but also in India. So now in India also, we are saving the tiniest and the sickest of the newborns. The neonatal care in many of the neonatal units in India are at par with the best and the most advanced centers in the world. I, being from a government sector, mine is a government hospital, I can vouch that the government is trying its level best to improve neonatal care, is laying a lot of emphasis on it, trying to penetrate deep into the peripheries, opening up of sick newborn care units in peripheral small hospitals, and training and sensitizing the manpower so as to reduce the neonatal mortality rates. Now, neonatal care, as all of you know, have a lot of challenges. But the most current challenge that we are facing nowadays is the current COVID pandemic. And in India, we are still trying to limp back to normal from the second wave, which is far from over as yet. So without any further delay, we will start with the talks. And to walk us through the very interesting talks, we have a very, very eminent neonatologist, Professor Rita Raman. Before I introduce Madam, I will request all the participants to please put your questions into the chat box. We will be answering all the questions at the end of the session. Now, I would like to introduce Professor Rita Raman. Madam is a professor of pediatrics at University of Oklahoma Health Sciences Center, USA. She is US board certified in pediatrics and neonatal perinatal medicine, and she holds a master's degree in biochemistry and molecular biology. Madam is the past president of the American College of Nutrition and International College of Nutrition. Professor Rita has served in many administrative roles as well, which includes Director of Special Care Nurseries, Director of Medi-Flight Neonatal Transport Team of Oklahoma, Director of Neonatal Perinatal Fellowship Program, and Associate Medical Director of the Heartland Health Plan of Oklahoma. During her bright career, she has been the recipient of several awards and recognitions and has lectured extensively both nationally and internationally. Madam was recognized as a top neonatal perinatal medicine specialist in Oklahoma and also as a leading physician of the world. So I now hand over the today's baton over to Madam to take over to introduce the speakers and start with the sessions.
Thank you, Dr. Rai, for those very kind comments. Good morning, ladies and gentlemen. Namaskar. I am very honored to be invited to participate and to chair this very important session. I extend my thanks to not only Dr. Rai, but to Dr. Ramesh Kumar and to Dr. Namit for their kind words, and also to the Indian Association of Pediatrics and to the Global Association of Physicians of Indian Origin for providing this wonderful opportunity. The reason I say this is a very important session is because two very important topics are going to be covered. One is the topic by the lecture by Dr. Sudeep Kukreja that talks about the golden hour, a term that we in neonatology have borrowed from trauma medicine, where this term originated. Now we know that it is very important. What happens in the first hour of neonatal care is as compelling and as relevant to long-term outcomes as is the first hour of trauma care. The other topic is the impact of the COVID-19 pandemic on healthcare delivery and all aspects of healthcare, if I may say so. And we have a very interesting lecture on that topic also. And in fact, that will be our first lecture, and that would be delivered by Dr. Thackeray will be delivering that particular.
Slight correction. First lecture is by Dr. Sudeep, and that is advances in NeoCare in the COVID times. And then is Dr. Rishikesh Thackeray doing the second topic.
Okay.
No problem.
So thank you for that clarification. So the first speaker will be Dr. Sudeep Kukreja, and then followed, as was clarified, by the lecture by Dr. Thackeray. So let me invite Dr. Kukreja to introduce him. He's a professor at the University of California in the United States. Professor Kukreja is an alumni of King's College Medical School in Lucknow. Professor Sudeep completed his DCH and his MD from Edinburgh and his MRCP and FRCS from UK, and completed his pediatric training in England and Scotland. Professor Sudeep completed his neonatal fellowship from Health Sciences Center in Winnipeg, Manitoba, Canada, a neighbor. Professor Sudeep is board certified and fellow of the American Academy of Pediatrics. So without too many additional words, let's hear from Dr. Sudeep Kukreja on this very important topic. Dr. Kukreja.
Thank you, Dr. Raman, and greetings from sunny Southern California to all of you. And I would like to, first of all, thanks. Let me just have my slides on. So I would like to extend my thanks to Dr. Tandon and the organizers for allowing this opportunity rather for me to share our experience during this pandemic from a 105-bed NICU. Our NICU is divided into 5 segments. And those segments are the general NICU, the SBU, where we provide cohort care for babies born with birth weight of 1,000 grams or less. And then we have cardiac NICU, neuro NICU, and surgical NICU, 5 parts of our NICU. And after giving you a little background of our unit at Children's Hospital of Orange County, we know that coronavirus have swept the world. It has literally swept the world and affected so badly every part, every segment of our life. And you all know the name Corona does not come from this popular beer in US. Corona is a Latin word, means crown. And it's the appearance of this virus under electron microscopy. It looks like a crown. So that is the reason. I know the Corona beer also have spread all over India also. However, so this crown appearance is as a result of the spike protein, the capsular spike protein of this virus. And this is the spike protein, showing S protein, call it. And there are a couple of other surface proteins, which we will not talk about at the moment. And it is this S protein which mediates the attachment of the virus to the epithelial cells, the human epithelial cells through the ACE receptors. Few of my pictorial slides I want to mention here come from Dr. Satyam, who is a neonatologist and professor of pediatrics at University of California, Davis. This is his slide. And after this attachment, that's the devastation happened in the epithelial cells. Then the objective of my talk today is to describe perinatal SARS-CoV-2 infection, summarize the clinical presentation, and describe the multi-system inflammatory syndrome in neonates, as opposed to C is N. So since we neonatologists our involvement is in the perinatal, so first couple of my slides are more related to pregnant mother. So we know pregnant mothers are more vulnerable to this infection comparing to the non-pregnant mothers who get infected. And the reason being because of the physiological changes happen during the pregnancy. For example, reduced cell-mediated immunity, then upward shift of the diaphragm, then increased heart rate, increased oxygen consumption, and even the higher risk of thromboembolism. And those all factors leads to higher vulnerability for pregnant mothers. And we also know from the US, pregnant women are higher risk of getting admitted to the ICU, requiring invasive ventilation and requiring ECMO. As a matter of fact, I may share with you, on East Coast, one pregnant woman had a cesarean section while she was getting ECMO therapy. And the mortality also is higher in pregnant women as opposed to non-pregnant women who are infected. So how we can prevent infections in pregnant mothers? Same old mask, very important part. And then of course, frequent hand washing, avoiding crowded areas, avoiding parties, and no more baby showers during this pandemic, and continue to maintain social distancing of 6 feet or more. Then another way to kind of prevent this infection in pregnant mother is vaccine. But unfortunately, there is a controversy related to use of vaccine in pregnant and lactating mother. Reason being, all the vaccine trials did not enroll pregnant mothers and the lactating mothers. However, despite that, the recommendation from ACOG as well as from the Society of Maternal Fetal Medicine is that we should give them a choice, explain the mother the possible side effects, especially the fever during pregnancy, etc., and then help the mother make decision to related to vaccine acceptance. So when it comes to mode of transmission from mother to the fetus, there are three potential ways of transmission: intrauterine transmission, which is vertical, intrapartum transmission, and the immediate postpartum. Intrauterine transmission is hematogenous spread through placenta, and the viral particles in the amniotic fluid the infant may inhale or swallow, and leading to the infection in the neonate. This route seems to be very unlikely. Then the intrapartum transmission, exposure to the infected maternal blood, exposure to infected vaginal secretions, and exposure to the infected feces. And then the third potential mode of transmission, which seems to be the most likely, is the postpartum during the afterbirth, which is exposure to the maternal respiratory secretions, exposure to the other healthcare workers who may have COVID, or exposure to the other family members. So this mode seems to be the more common mode of transmission of this virus from mother to the newborn. So now I will walk you through US experience, what we faced, and I'll walk you through as a woman, pregnant woman, term or preterm, is admitted to a hospital in labor. So the first thing happened is the PCR testing. If the mother is positive, then the mother is transferred to the negative pressure isolation. And if she's negative, then she goes to the regular L&D part of the obstetric department. So once she's admitted to, if she's positive and admitted to the negative pressure room, there minimum number of care providers to control the infection. And the mother also is given a surgical mask to wear. And all the members, caregiving members of the medical team wearing full infection prevention PPE, N95 peppers or cappers, double gloves. And if the infant is also going to be treated in the same room, means the regular NRP care or resuscitation you may require, then we have a resuscitation on the warmer 6 feet away from the mother's bed, and maybe a curtain in between. Even that prevents the spread of infection between mother and the fetus. Then if an infant after is born, of course, delayed cord clamping, early on in the pandemic, there was little hesitancy, but then later on, based on studies that this virus does not transmit through the breast milk, the recommendation from World Health Organization, as well as from American Academy of Pediatrics, was to have, or rather endorse breastfeeding, delayed cord clamping, as well as immediate skin-to-skin contact. So in the delivery room where the mother is, the same for the baby, we follow the NRP guidelines, and all the team members again would have the full infection control measures, which I explained earlier, like the OB team does. So there's the neonatal team. And sometimes you may need extra people. So those extra people do not come into the room. They stay outside the door. If we need extra help, extra hands, then they are allowed to come in, again, to prevent spread of infection. And from our US experience, we know the mothers who are born or not mothers who are born, the mothers who are COVID positive, 1 to 3% of the kids born to the positive mothers are also positive. And once we see that after the infant is born, if the infant requires further care, further NICU care, then the infant is transferred in an isolate to the NICU, where again, the healthcare givers full PPE and full infection prevention measures. And infant get PCR done at 24 and 48 hours a day. And we know from our experience here, the COVID, this population, the rate of prematurity has increased, or it is higher than rest of the population. Like in US, the prematurity rate at the moment is about 10.2% versus in this population, COVID population, the rate is about 13%. It has a higher, these babies are also at higher risk of being born low birth weight and increased cesarean section rate. That should not be, but unfortunately it is. Like the mode of delivery, cesarean section versus vaginal delivery versus, for example, vacuum extraction or all, that should be, it is based on the obstetrical indication. Being COVID positive is not an indication to do a cesarean section. So cesarean section rate should not be higher, but however it is. I can tell you the overall cesarean section rate in US is about 32% versus during the COVID, it has been more 35 to 41% in this population. Then, like I stated earlier, breast milk use, if the infant is with the mother, is endorsed by World Health Organization as well as American Academy of Pediatrics. And the mother should use mask, hand washing, and breast washing with soap and water prior to feeding. And in between feeds, infant should stay in crib, which should be kept away, again, social distancing, same distance, 6 feet away from the mother. And if it's a preterm infant or the infant is admitted to the NICU, in that case, mother could pump the breast and give the extracted breast milk to the infant. Why infants and children have milder illnesses? Probably as a result of immature immune system and protection from the maternal immunoglobulin. And infants also have low expression of these receptors on the epithelial cells. However, neonates, as opposed to older infants, more severe illness. And that is almost, my slide here. 1 second. The risk of neonates getting admitted to the NICU is almost 12% as compared to older infant, about 3% if they are COVID positive. Then the clinical presentation in newborns is, it could be an early onset, late onset, or a rare condition, which I stated earlier, which is multi-system inflammatory syndrome in neonates. So let's talk about the early onset neonatal sepsis, usually asymptomatic and usually as a result of perinatal transmission, and the infant present within 2 to 7 days of life with the temperature instability, feeding difficulties, nasal congestion, respiratory cyanosis. And when it comes to the late onset neonatal sepsis, many infants are negative at birth, even with the positive mother, and they go home. And then they are admitted back after 5 to 7 days of age to the hospital with temperature instability, again, non-specific opacities on the chest X-ray, feeding difficulties, respiratory distress. And usually it is, like I said, postnatal transmission or the horizontal transmission. And the labs may show leukocytosis, lymphopenia, thrombocytopenia. So I will share with you this cohort study of 61 newborns with COVID-19 requiring admission. So half of those infants had a known contact with infected individuals. They could present with hypothermia, hyperthermia, tachypnea, coryza, apnea, mild respiratory distress, feeding issues. And half of those infants showed non-specific opacities on chest X-ray. And I would say about 1/3, about 30%, or 28% to be precise, so ground glass appearance of the X-ray. And 1/3 of these infants did require oxygen and respiratory support. And we already talked about the labs, thrombocytopenia, elevated lactates, elevated CD-active protein, lymphopenia. And then another factor noticed was if the infant is admitted less than 1 month of age, there's 3 times higher risk of that infant requiring intensive care. As far as the treatment parts or the management is concerned for these infants, is all symptomatic and supportive. Oxygen and respiratory support, fluid resuscitation, and temperature control. And as far as the usefulness of remdesivir and steroid, and as well as convalescent plasma is concerned, there is lack of evidence. And this lack of evidence makes the management even more challenging, although there are some anecdotal report of benefits of after use of these agents, especially IVIG use in infants with multi-system inflammatory syndrome. So this slide's just showing the presentation of the multi-system inflammatory syndrome. It is as a result of hyperimmune neonatal response to the maternal antibodies. And the hallmark of this is the cardiovascular involvement, the myocarditis with increased troponins, increased BNP, coronary aneurysms like we see in Kawasaki syndrome. And then, of course, hypoxemia, they could have pulmonary hypertension, can develop colitis, and sometimes picture very much mimicking necrotizing enterocolitis. And this is not very common condition. Fortunately, it's a rare condition with a very high mortality. And there have been, like I said, few anecdotal reports of benefits from IVIG infusion. So to summarize, COVID-19, thank God, is much less frequent in newborns than in adults. And the lack of high quality evidence makes the management more challenging. Another issue comes as mother-baby separation as a result of isolation may have long-term mother-infant bonding issues. Then ACOG and AAP recommends vaccination of the pregnant woman. As a matter of fact, just last week, last Wednesday, NIH started a trial of vaccine use, vaccine for pregnant women and lactating women. And the results of that trial should be available sometimes later in the fall. And as a matter of fact, again, a trial for 5 to 12-year-olds also started about a couple of weeks ago. And again, those results should be available later in the fall. So no vaccine trial in the newborn population at the moment, although things are a little stabilizing, improving, we are still not out of the woods. I will stop here and question, I suppose, at the end. Thank you.
Thank you so much, Dr. Kukreja, for that lovely presentation. You did an excellent job covering this area in a very comprehensive way, and your slides were outstanding. As you mentioned, the Q&A session will be in the end. So let me move on and introduce our second speaker. We are in for another wonderful talk. The second speaker will be Dr. Thikhare. Dr. Thikhare is from Aurangabad in India. He has a very distinguished background. Dr. Rishikesh Thikhare is a consultant neonatologist at the Neo Clinic and Hospital in Aurangabad, Maharashtra. Dr. Thackeray did his DM in neonatology from Lokmanya Tilak Municipal Medical College and Sion, Mumbai. Dr. Thackeray has served as editor for 6 books, presented over 100 posters, published 30 papers, contributed to more than 50 chapters in textbooks, and delivered more than 300 guest lectures. Dr. Thackeray has been the past chairperson of the Indian Academy of Pediatrics Neonatology chapter and vice president of National Neonatology Forum India. His areas of interest are clinical neonatology and resuscitation, and is passionate about teaching. And with that, I bring to you Dr. Rishikesh Thackeray and this very, very important lecture. Thank you. And Dr. Thackeray?
Okay. Thank you very much, Madam, for those kind words. Hello to everyone across the globe, and good evening, fellow academicians. It is indeed a pleasure and a privilege to be with you all here today. And my sincere thanks and gratitude to the organizers, Dr. Tandon, and the IAP and the GAPIO for giving me this opportunity to be with you all. Well, the topic for discussion would be care of the newborn in the first hour of life, what is called as the golden hour. Well, we do know that if we change the beginning of the story, we change the whole story. And this is very much true when it comes to the newborn. For in the first hour of life, what is also called as the golden hour, we would have a host of interventions that would be targeted in the delivery room and thereafter in the newborn nursery. And these would be interventions which are simple, effective, evidence-based, and would have a huge impact, both short-term and long-term, in terms of neonatal outcome. And let me walk you through these simple steps which each of us can practice to give a warm welcome to the newborn. Well, there has been a growing shift that it's not only the clinical skills that would matter, but there would be soft skills which also would be required if we wish to make an impact as a team together with a growing emphasis on communication. Mind you, these interventions are time-bound and therefore a need to be structured and organized. Well, the focus in the delivery room is no doubt on resuscitation, and we are well aware that the steps of resuscitation essentially are required in less than 10% of newborns. And the key point and the 2 milestones that I wish to touch upon, which should be kept in mind in the delivery room, are A, the golden minute. The 3 mantras, if we have to perform well in the newborn resuscitation, if we have to keep in mind, would be A, failing to prepare is preparing to fail. What it means is we need to get organized prior to the arrival of the newborn by getting things of person, place, and equipment in order, and an equipment checklist would be handy at this stage. The second mantra would be brief and debrief. What it means is prior to arrival of the baby, based on the risk factors, we would assign roles and responsibilities and anticipate problems, and if time permits, counsel the parents. Debriefing happens at the end of the resuscitation on what things went well, what we could have done better, and what are the areas of concern that would need further, what you can say, care. And last mantra is teamwork. And team stands for together, each achieves more. And if we want to succeed as in newborn resuscitation, the paradigm shift which has happened is shift from a person-oriented resuscitation to a team-based approach. Now, there were 2 milestones that I wish to draw your attention to. The first is the golden minute. For those newborns who do not breathe at birth, one would be prompt enough to take initial steps and if required, initiate positive pressure ventilation within the first minute of life. Unlike the pediatrics and adults, where the primary pathology is with the heart, in the newborns, the primary pathology is with the lungs, and therefore the entire emphasis is on ventilation. And it is not just ventilation, it is about effective ventilation. And therefore, the entire emphasis is not to delay ventilation in the delivery room beyond first minute or first 60 seconds, and what is constituted as the golden minute. The second key point, or the second milestone that needs to be looked at, is that by 5 minutes, the oxygen saturation should touch 80% or more, and if not, at least the heart rate should have crossed 100 per minute. So what it tells us is the first golden minute and the 5-minute hallmark are something that we need to work upon and ensure that we put all in our efforts to meet these two hallmarks. So 3 mantras and 2 milestones is all that we need to keep in mind as far as resuscitation is concerned. Well, we must realize that 90% of newborns would not need resuscitation, but they would need two simple, effective, evidence-based interventions which are under-recognized, underappreciated, and underperformed. And the first simple intervention that needs to be performed on all healthy newborns, whether term or preterm, is to place the baby following delivery onto mother's abdomen for early skin-to-skin contact. So the key here is zero separation between the mother and the baby. Well, there are immense benefits to the baby in terms of thermal stability, glucose stability, reduce requirement of oxygenation, lesser risk of infection, but so also immense benefits to the mother in terms of improvement in terms of performance for breastfeeding, lesser stress, reduced postpartum hemorrhage, and increased bonding. What we need to understand is, following the early skin-to-skin contact, breastfeeding should be initiated within the first hour of life, and we would soon realize that there is dose-response relationship between breastfeeding and short as well as long-term benefits, which extend not only into the neonatal period, but into the infancy, childhood, adolescence, and probably into adulthood. So the first intervention which has to be performed for all healthy, well newborns in the delivery room is skin-to-skin contact. The second intervention is delayed cord clamping. Again, this intervention demands masterly inactivity from us and be there for all the babies who have established breathing or crying, and wait for next 60 seconds or 1 minute before you cut the cord. So there's no hurry today. Science tells us the benefits are immense when it comes to preterm, and the key point here is not only decrease in terms of morbidity, but more importantly, improved survival. And the benefits also are more so for term newborns and more so in low resource countries and middle income countries in terms of improved hematological parameters and reduced incidence of iron deficiency anemia. So masterly inactivity, wait for first minute, and thereafter cut the cord. Well, we would not cut the cord or perform delayed cord clamping for those babies who require resuscitation. We would cut the cord immediately. Well, what about if the mother is seropositive or has hepatitis B? WHO recommends delayed cord clamping since the benefits outweigh the risks involved. The risk is minimal and does not merit intervention as far as the newborn is concerned, but we need to be aware and follow these newborns for development of polycythemia or hyperbilirubinemia. There is few situations where you would not perform delayed cord clamping, and one we said was resuscitation, the other being placenta previa, abruptio placentae, vasa previa, or avulsion of the cord. What we also realize is cord milking is today not considered as standard of care. Those babies who were subjected to cord milking, in addition to delayed cord clamping, studies show that they were at risk for developing higher incidence of intraventricular hemorrhage, especially in very preterm babies, though there was some benefit in terms of reduced transfusion, but no improved clinical outcomes. So cord milking today is not standard of care. So the second intervention that needs to be performed, first we talked about was early skin to skin contact and delayed cord clamping. No newborn today should be denied the benefits of these simple, effective interventions. Well, we also realize that hypothermia is common in the newborns, especially so for low birth weight and preterm babies. And we do know that it is an independent marker or predictor of mortality. There is dose-response relationship between hypothermia and mortality. For every 1 degree Celsius drop in temperature, the mortality is increased to a tune of about 28%. And hypothermia begets hypoglycemia, hypoxia, respiratory distress, and predisposes to sepsis. And therefore, what is expected from us is a warm welcome to all the newborns. And especially if you are having a preterm baby, what is expected is a thermal bundle, which would include getting the baby under the warmer, placing the cap immediately. And for babies who are very preterm, one would put it in a plastic wrap or a cling and use a thermal mattress if required. These set and bundle of interventions are of immense benefits, and the target temperature to be looked at before, during, and after resuscitation is 36.5 to 37.5 degrees Celsius. In our urge to warm up the baby, let us realize that hyperthermia is equally detrimental. So what is the take-home message? No baby should leave the delivery room without having documented temperature, for this is a simple quality marker of your care in the delivery room. The commonest drug that is used in the delivery room is oxygen. And like any other drug, it has a dose, it has a duration, and it has its own side effects. Today, newborn resuscitation program recommends initiating room air for babies if they need positive pressure ventilation who are beyond 35 weeks of gestation. And for those babies who are less than 35 weeks, we would start somewhere between 21 to 30%. Mind you, we would document and look at the preductal oxygen saturations. And we know there is minute-specific oxygen saturation which takes place. There is only one situation in the entire lifeline of the newborn when he would be subjected to 100% oxygen, and that is with chest compression. What it demands is that if you are starting oxygen, you would have a pulse oximeter, preferably the one which is based on signal extraction technology. And more importantly, the dose of the oxygen should be titrated by use of a blender. And that probably is a hurdle as far as low resource countries are concerned, for what that would demand compressed air and oxygen in the delivery room, which may not be always available. So use of oxygen has to be objective. The target oxygen saturation we would be looking at is 90 to 94%. Well, beyond the delivery room, there is an area of concern, which is the weakest link in the care of the newborn in the first hour of life. That is from the delivery room to the newborn nursery, and that is transport. We just must realize that however good we may be in our delivery room care, and however good we may be in terms of our intensive care, the weakest link may bring about a huge change in terms of the neonatal outcome. What we must realize is the neonatal transport has to be structured and organized, and there are ways and means like stable approach, a safer approach, or what we practice is the TOPS approach, that is before, during, and after transport, focusing on temperature, oxygen, perfusion, and sugar. What we also know is longer the delay in transport, higher is the risk of morbidity, if not mortality. The commonest problem in the nursery that you're going to face in the first hour of life, especially if it's a preterm baby, would be in terms of respiratory distress. And in the delivery room, if facilities permit, for all those newborns who have work of breathing, one would start with positive and expiratory pressure through a TP resuscitator in the form of delivery room CPAP. And it has been found that use of delivery room CPAP decreases the need for intubation, need for surfactant, and mechanical ventilation. There would be subset of babies who would develop respiratory distress in the NICU and not there in the delivery room, sometimes in the first few hours of life. The gold standard today is non-invasive respiratory care in the form of a continuous positive airway pressure. And the drug of choice that you have is surfactant for preterm babies who develop early onset respiratory distress. We would be not looking at prophylactic surfactant in the modern era, and the entire emphasis is to start with early CPAP and use early rescue surfactant. And the threshold to provide surfactant would be based on a need for oxygen of about 45% or a CPAP pressure beyond 6 centimeters of water, or if there is need for intubation for providing ventilation. We realized that we would intubate the baby, give surfactant, and extubate back the baby to ongoing CPAP support, what is called as ensure technique. However, today the evidence tells us that less invasive surfactant administration or minimally invasive surfactant therapy has an edge and is the way forward. Mind you, this is the only intervention which has been shown to reduce the incidence of chronic lung disease. And what it means is we would, instead of intubating the baby, continue with CPAP and just put in a soft catheter or a special feeding tube, or maybe consider putting a laryngeal mask airway with ongoing CPAP and then administer surfactant without discontinuing the ongoing respiratory support. And this LISA or MIS technique demands a learning curve if you wish to practice in your unit. What is known also is that for all those babies who would need non-invasive or invasive respiratory support, early caffeine is in order. And for those babies where you practice LISA or MIS, the need for ventilation, air leak, bronchopulmonary dysplasia, and or death is significantly reduced. So what it means is in today's era, very few babies would end up with an endotracheal tube, especially if you have been prompt enough and their mother has received antenatal steroids. This would be a brief summary of what would be the best strategies in terms of respiratory support. Well, we do know that nutrition is the key for newborn outcome, and especially for preterms. I recollect my teacher telling us that birth of a preterm baby is a nutritional emergency. And the entire focus today has shifted on to mom, that is mother's own milk. A novel nutritional intervention is oropharyngeal colostrum, and a systematic review done showed that the benefits are immense, both short-term and in terms of reduced mortality. What we also know is the preferred choice, the gold standard for newborn nutrition happens to be mother's own milk. And if it is not there, all efforts must be made to use donor human milk. There is a dose-response relationship with the use of formula, and that would be a single most risk factor for developing necrotizing enterocolitis. Well, for those babies who are very preterms, one would initiate early proteins right there within the first hour, and then build up on lipid supplementation in the form of parental nutrition. A paradigm change which took place was with this study, which showed that if the baby is stable and there is no need to be conventional in terms of enteral feeding of increasing feeds of 20 to 30 cc per kg per day, but you could start on total enteral feed and the benefits were immense. It did not lead to increased incidence of NEC, sepsis, and or death. What has been the major change as far as the golden hour care is concerned? Well, this study, which was conducted across 5 countries, of which one was India, showed that if you are able to initiate kangaroo care, that is early skin to skin contact, right from 0 hours versus what has been a standard of care to stabilize the baby under a warmer. And then once the baby is stabilized, initiate kangaroo care. Early initiation of kangaroo care improved survival. And no doubt there were other benefits that were also noticed in this study. Well, so we have learned about a host of interventions. The point is, how do we put this into practice? Simply because there is a gap between what we know and what we do. And this is through science of improvement and feasible and possible through QI, what is quality improvement. And what we realize that if we are looking at individual steps, each of these has a potential to give rich dividends. So what is expected of us is through all the strategies that I enumerated, do a assessment in terms of structure, process, and outcomes, and think what would best work in your unit in terms of changing the package of care, making use of checklists or bundles, and have a strategy which would work in your unit. Mind you, there is no single one fixed formula which will work in all the circumstances. So if you wish to put your golden hour to a golden start, to initiate quality improvement right from the delivery room to the admission in the NICU. So to conclude, what would be the best clinical practices in the golden hour for our newborn? In the delivery room, zero separation, delayed cord clamping, early skin to skin contact, use of checklist, use of thermal care bundles, and if required, initiating ventilation in the first golden minute. For those babies who need transport, we need to have it to be structured and organized. In the NICU, use oxygen as a drug, provide early non-invasive respiratory support, and if required, early surfactant through LISA or MIST technique. Nutrition in the form of mother's own milk, early colostrum, express breast milk, donor human milk, early parenteral nutrition is the key. And last but not the least, the best way to go forwards is to identify and improve the gaps in the care in your unit. These would be the simple strategies we would and we must implement to get the newborn to a golden start in the golden hour. Thank you very much for your patient listening.
Thank you, Dr. Thackeray, for that excellent lecture addressing the golden hour in neonatal care. Particularly interesting and important is the fact that you emphasize aspects of this NRP guidelines, not just for the high-risk newborns, but for all newborns to make the first hour transition warm, welcoming, and optimum. Because we see more of normal healthy babies than are statistically likely to be born high risk or premature. So that emphasis and the benefit that confers is so important. That I see there are many important and interesting questions in the chat box. So without taking too much time, I once again thank you, and I will ask the moderator, Dr. Ruchi Rai, to start the question and answer session by taking questions that have already been placed in the chat box. And Dr. Rai?
Yeah, thank you so much, ma'am. And firstly, I would like to congratulate the speakers for very crisp talks and giving key messages. So we'll start straight away with the questions. And the first talk was by Dr. Sudeep Kukreja. And the first questions that I will be, the questions which have been put first are regarding the COVID status of the mother. So the first question is from Dr. Saroj Kumar to Dr. Sudeep. When is the safest time to vaccinate pregnant mothers? Is sir there? Is Dr. Sudeep with us?
I doubt, I don't see him. So I know Suraj Kumar from Canada. We will pass on this question to Dr. Sudeep, and all questions for Dr. Sudeep, because he said he had it wrong. So we are very extremely sorry. You can direct if Dr. Rishikesh Hartway would like to answer. Most welcome.
Can you repeat the question, please?
Yeah, the question by Dr. Saroj is, when is the safest time to vaccinate pregnant mothers?
Okay. Well, recently the government of India changed their guidelines, and today all lactating mothers have been made eligible for vaccination for COVID. As far as vaccination for pregnant women is concerned, again, recent change has happened as far as the guidelines are concerned, and one would hesitate to give it in the first trimester, and definitely we would offer 2 doses to all the mothers, simply because they are high-risk candidates, and the second dose has to be preferably completed before the 3rd trimester, simply to give maximum protection, not only to the mother, but also to the baby.
Okay, rightly so, sir. So the next question is, if the pregnant women have COVID-19, is it possible for the child not to contact it?
Yes, we do know that the only way by which a newborn contracts COVID-19, fortunately, is not through vertical transmission. That's extremely rare, though anecdotal reports have been made. And therefore, we also do know that breastfeeding is not a mode of transmission as far as the newborn is concerned. And therefore, again, you are left behind with a mother who goes on to have COVID-19, sometimes 2 weeks prior to the delivery, develops antibodies, passes them on to the fetus and to the newborn, and therefore the commonest presentation becomes a late onset sepsis mimic that we should be aware of, especially where and rarely one would end up with a multi-system inflammatory response, which again would be a consequence of antibodies which the mother developed, which she passed on to the fetus, like it happens in RHSO immunization. So for all practical purposes, mother and the newborn have to be together, especially if they are asymptomatic. Zero separation at birth, early and exclusive breastfeeding is the way forward. And a high index of suspicion. If you have to detect COVID-19, our recommendations indicate that you would do a COVID test on the newborn between 24 to 48 hours of life, and if required, repeat it on day 5 or between day 5 to day 10 of life.
Yeah, so Dr. Sudeep also in one of the slides showed that in his cohort, only 1 to 3% of the babies actually turned out to be RT-PCR positive. Okay, so now the question by Dr. Suman Sen is regarding the mRNA vaccines which are being given by the Moderna and the Pfizer. And Dr. Suman wants to know, isn't it more safe to give these vaccines to pregnant women? Because we know that mRNA cannot react with the DNA or cause any genome to change because it does not enter the nuclear or the cell of the cell, the nucleus of the cell.
Correct. So if you see the recommended vaccine is definitely the mRNA vaccine. Unfortunately, that vaccine as of now is not available in our country. So you have to use the second best vaccine. And even in UK, where the same vaccine of AstraZeneca is being used, the Royal College there would recommend vaccination for pregnant women.
Okay.
So the benefits are far more than the risk involved, even if you use a non-mRNA vaccine.
Definitely. So we, all of us are waiting for the government of India to okay the vaccination for pregnant women also. So the next question is by Dr. Neha Tyagi. She wants to know, because Dr. Sudeep in one of his slides had mentioned that the breast should be washed with soap and water before each breastfeed. So she wants to know if the mother will frequently wash breast with soap and water and develops nipple cracks, then can we just wash it with plain water?
Agreed.
So I think that should not be a problem. I don't think actually we need to wash it with soap. Probably we are not recommending that here. The next question is by Dr. Kalpana Datta. How many cases of multisystem inflammatory syndrome in newborns have you seen, sir? This was for Dr. Sudeep. Dr. Rishikesh can answer. Yeah.
Okay, if we look, okay, in my practice, I have yet to see a MIS-C in the newborn, but in children, I have seen a couple of them. If you look at the literature which has come from India, almost every issue of last 4 months would have a case report or a case series which has shown MIS-C in the newborn, but these are still extremely rare.
And I think really overdiagnosed, because I find a lot of people asking, could this be MISCN? Any newborn presenting with sepsis-like syndrome? So first thing coming up to everyone's mind is MISCN.
Well, if you want, if you want to make a diagnosis of MISC in the newborn, please use a checklist in the form of either the CDC or the WHO criteria. A. B. This is a diagnosis of exclusion. You need to rule out all treatable and known conditions. And for all practical purposes, majority of our newborns either have asphyxia or sepsis or a metabolic problem or underlying medical or a surgical issue. A. Further, having said that, there is a tendency to look only at antibodies which are coming positive in the test and jumping onto a diagnosis. Remember, IgG may be passively transferred, and just presence of an antibody would not mean that this is MIS-C-N equivalent.
Definitely. So Dr. Richa Jaiswal wants to know how many newborns needed formula feed and for how long. I think she's referring to...
We do not recommend formula feed to COVID mothers. The preferred choice is mother's own milk.
Definitely. Dr. Bhaswati Ghoshal wants to know why mother-baby separation is there.
As I said, there is zero separation which is recommended.
I think one of the slides Dr. Sudeep had shown the impact of pandemic. One of the points he had mentioned was mother-baby separation and long-term impact. So probably that's what she wanted to know. From Dr. Gunjana Kumar, what is the rate of perinatal infection?
Perinatal transmission is extremely rare. If you are asking about how many of those babies born to mothers go on to develop, maybe 1 to 3% go on to develop COVID positive status.
Dr. Anwar PV wants to know, are there any reports of cross-infection among newborns or from newborn to healthcare workers?
None that I am aware of.
So is breastfeeding safe? Yeah, so I think we have answered that question very clearly. Dr. Amandeep Singh wants to know, why aren't children getting very sick with COVID?
That's the million-dollar question, which we haven't been able to crack. Good thing is they are safe, we are safe.
Yeah, true. So Dr. Adabala Soumya wants to know, did breastfeeding mothers can take vaccine?
Yes.
Definitely. So in India also now it is allowed. From Dr. Aditya Mohapatra, whether oropharyngeal swab of a newborn will give the same result as nasopharyngeal for RT-PCR.
Less sensitivity, you are likely to miss the diagnosis. Preferred is the nasal swab. So ideally both nasal and oropharyngeal swab.
Dr. Neha Tyagi wants to know how glucose stabilization happens in skin-to-skin contact.
Multifactorial. Your temperature is stabilized. That per se reduces the stress on the newborn. Otherwise, the moment you become hypothermic, the entire machinery in terms of homeostasis gets deranged.
And then skin-to-skin contact will promote early breastfeeding and all that. So
so can I share before we get off the COVID, can I share a brief comment on what we've covered? I think their questions have been answered in a very excellent way. My one caution is I would not automatically assume that any particular vaccine is better in the pregnant population than another until we get data. Because as we find out, in each population, there's a unique risk. For example, the adenovirus vaccines were associated with brain clots. Again, in pediatric population that are being studied with the Pfizer mRNA vaccine, the risk for myocardial involvement is higher, something that was not seen in the older population. So I think each population has its own immune regulation variances and its own responses to vaccine. So I think it could be better, but we don't know that for a fact. So we have to wait for more research on pregnant population and their risks before we can say any one thing is necessarily better than the others. Just a word of caution on that.
Yes, true, ma'am. So, ma'am, can we continue with the questions?
Yes, please, done.
Oh,
Just a brief
thank you.
comment before we switch to the golden hour.
Yeah, definitely, ma'am. So, firstly, I would like to thank Dr. Rishikesh for taking up the questions for the first talk as well. So, the next question from Dr. Kalpana Datta is, in NACO guidelines 2018, baby of HIV positive mother, early cord clamping is recommended.
Well, it's the WHO 2014 document that I quoted, and it's the benefits outweigh the risks involved, and therefore it is suggested that you would prefer using delayed cord clamping also in these subset of mothers.
Yeah, I think there is no doubt that
Can't hear you, ma'am.
Yeah.
You are muted.
okay, sorry, I was muted. Yeah. So, Dr. Neha wants to know if the mother has heart disease, should we do delayed cord clamping still?
Not that I am aware of any harm that would likely to happen to the newborn. I do not foresee any medical condition of the mother except that I outlisted in terms of placenta previa, vasa previa, that would come in the way. So I would not hesitate to do delayed cord clamping in such situations.
So Dr. Yashwant had a similar question regarding washing of breast with soap and water. So I think we have already addressed that question. Dr. Ravi Agrawal, I'm a strong supporter of golden hour. However, I wonder if you could quote with good articles supporting golden hour in newborn babies.
Yes, if you see, my last slide showed a host of interventions, which unfortunately for lack of time, I didn't go through all of these. These are all evidence-based strategies that have been tried. And the way that these golden hour strategies have been tried, if you just do a little PubMed search, you will realize these are all QI projects which have happened in the delivery room. And if you are still interested, I can share these articles with you.
Dr. Anita Sethi is stating that preterm baby requiring NICU care will be separated from the mother. According to guidelines, babies weighing less than 34 weeks or weight less than 1800 grams require NICU admission, so separation from mother.
Okay. Obviously, if the medical condition demands, the baby would be shifted to nursery.
Definitely.
So this would be case-by-case basis in that situation.
Dr. Saravanan, early rescue or selective surfactant administration based on FiO2.
Okay. If you look at the literature, the figure is somewhere 0.3 to 0.4. If you look at the Cochrane review that I quoted, it is 0.45. We in our practice use a FiO2 threshold of 0.4.
So Dr. Anwar wants to know, sir, could you kindly define early caffeine?
Okay. If you look at the studies, the early caffeine is somewhere in the first 48 hours. And definitely, majority of the babies receive it as early as possible. And the only way you would start them would be if they are in need of some form of respiratory support, either non-invasive or invasive.
Dr. Samuel wants to know which recommendation advice for giving surfactant through intratracheal route to neonate with COVID-19 or mother is positive for COVID.
Well, I would still say that mother's COVID status will not come in the way of surfactant delivery. A, B, if you want to intubate, please take extra precautions. You need to wear, in addition to an N5 mask, you would need a shield, and some of the units also use a plexiglass in addition as a further protection, simply because this is an aerosol generation procedure. And if you have proficiency in terms of LISA or MIST with use of a catheter, that would avoid using endotracheal intubation, and that would be still further safe.
Thank you, Dr. Ruchi. I think you have come to an end of the questions. So rest of the questions can be sent if they are not answered to the email ID I have mentioned in the chat box. And now you kindly request Dr. Namit to do the closing remarks.
Okay, sir. So we'll be answering the questions will be given to the speakers, and They will be replied through email. Now I will request Dr. Namit to please give a vote of thanks.
Thank you, Dr. Rai. I thank for this opportunity to be here and participate in this exciting and important session. I now invite Dr. Namit Jairat to do the closing remarks and to thank the speakers, moderator, and audience and the organizers, and also the support team for their participation in this very important session. Dr. Namit Jairat.
Thank you, madam. It has been an excellent session. Both the sessions were very interesting, very well received by everyone. And with the questions that people have put in the chat box, I can see there's a long list and we could have gone on for a very long time. But yes, it's an honor for me to thank everyone involved, especially both our speakers, Professor Dr. Kukreja and Dr. Thakre. Both have been excellent. Thank you to you, ma'am, for taking out time, Professor Dr. Rita Raman. And I would also like to thank our moderator, Professor Dr. Ruchi Rai. It has been a great session and you all have done excellent work for this. Thank you so much. I would like to also thank Dr. Ramesh Kumar for having taken out his time from his busy schedule, and all the officials of the Indian Academy of Pediatrics and the GAPIO for having been with us. There have been lots of people who have been working behind the scenes relentlessly, including Dr. Tandon, who has been working very hard for the last so many weeks for every session, and the IT team. A special thanks to all of them. I think if I have missed out some names, there's a huge thank you to everyone. Good night, good evening, good afternoon, wherever you are.
I would like to acknowledge the presence of you, of the people, those who every participant, and our current president of IAP, Dr. Piyush Gupta was there. Dr. N.N. Datta from Guwahati specially attended this session. Dr. Anju Agarwal from Australia. Dr. Pawan Kapoor, Air Vice Marshal, you attended the session. Dr. Ganguly attended the session. And Saroj Kumar, especially from Canada, she attended the session. And we thank Vishwant Patel from USA and Prashant Patel and everybody for attending this very interesting topic. Thank you very much, everybody. And hope to see you again on our next session on 31st of July, again on a very interesting subject. Thank you very much.
Thank you, Dr. Tandon and
Thank
Dr.
you.
Namit.
Thank you very much.
And the
Thank you.
Thank you.
Thank you so much.
Great job, Dr. Tandon. So impressive.
Thank you, sir. Thank you very much.
Thank you. Thank you, Dr. Tandon.
Thank you very much, Dr. Rita. Thank you.
Good day this side and good day, ma'am.
Good night. Thank you. And sit.